thank everyone who is taking the time to join me today for just a brief discussion on abdominal pain and fibroids and some minimally invasive treatments that are useful in the treatment of fibroids. Just by point of reference, this webinar will then be available at some point on YouTube, and those who register can get a copy and watch it again in the event that you missed any part of it, which I know occasionally happens. In any event, this is just a little bit about me. I am an interventional radiologist, which means I use image guidance to perform procedures, which includes ultrasound, X-ray, CAT scan, etc. And I've been doing this for almost 20 years or so. So today we're going to talk a little bit about what are uterine fibroids, what are common causes of fibroids, some symptoms of uterine fibroids, what causes some abdominal pain and cramping, what is constituted as a normal period versus an abnormal one, and then a little bit about treatments. I mean, actually a fair amount, hopefully, about treatments. And then we talk a little bit about how we do some virtual appointments currently for people who are interested in getting treated sometime in the near future when it's becomes more safe to do so. So what are uterine fibroids? So basically, uterine fibroids are non-cancerous tumors that develop inside the uterus or on the uterine lining. So according to a 2018 survey conducted by the Journal for Women's Health, about 11 million women in the United States have uterine fibroids. I think it's actually a little bit higher than that, but this is just a survey that was done. Now, fibroids are unpredictable. There's no direct cause. What we do believe is that estrogen and progesterone do play a role in their development. And we also do understand that there is a genetic predisposition to developing uterine fibroids. So, as I said earlier, we do understand that the female hormones like estrogen and progesterone are involved in the development of fibroids. So we can see here that on this little chart on the right, that what has been established is that during pregnancy, fibroids increase in size. And then at menopause, it's well established that fibroids then decrease in size. In fact, many people believe that menopause is a quote unquote cure for fibroid disease. And it is in fact true that after menopause, most women's fibroids shrink. We also see that hormone replacement therapy prevents shrinkage of fibroids. So that's what led people to understand or believe that the female hormones like estrogen and progesterone are involved in uterine growth. Now, what are the different types of fibroids? Okay, so I like to break them down, and I'm not the only one who breaks it into the following categories. One is intramural. These grow inside the muscular wall. So this is considered a intramuscular fibroid. Okay, now fibroids are all benign tumors made up of muscle cell or muscular tissues. Okay, that's why the technical term for them is leiomyoma, which is a smooth muscle tumor of the uterus. Now there's subserosal fibroids. They grow on the outer lining of the uterus like this, and they bulge out. And in doing so, they often cause symptoms of pressure or pain, depending upon what the adjacent structure is that they push on. So you can imagine if they push in the front, it causes some symptoms on the bladder. In the back, it can cause symptoms on the bowel or nerves, and we can show a little bit about that in a few minutes. Now, the other type of fibroid is a submucosal fibroid. Now, this is the one that we find causes the greatest amount of bleeding. So they can be just inside the inner lining. This pink here is the submucosa, and the endometrium is right here. So when these fibroids grow underneath, they can irritate this lining and cause heavy bleeding. This is what's called a pedunculated submucosal fibroid, or some people will refer to it as intracavitary because it's inside the cavity of the uterus. These are all different types and terms, and some are more specific than others. Again, here's another schematic showing the different types of fibroids, and one should understand that this is a subserosal, submucosal, and intramural. And many women have all three of these. So in fact, it's not like you have one. Typically, many women have multiple fibroids, and if they do, they have almost always a complete variety of these fibroids. So here's an image from an MRI, and while no one would expect anybody to interpret these images, In fact, in this little small picture, you can see it says fibroids, and here is a uterus that is growing all the way up to here. Here's the belly button. So you can see this is just a little bit below the belly button. It's a pretty big uterus. This is the lower back. So you can see, as I was saying, that these fibroids can compress or press along the front of the uterus and push on the bladder. This white area here is the urine or water in the bladder. And you can see if it goes back, it can push on other adjacent structures. We also see that when we give contrast on an MRI, these contrasts enhance, which means they take up the contrast, which gives us an idea or an understanding about how vascular these tumors are. And in fact, it's their vascularity that we're counting on to allow us to make fibroid treatments effective. So eventually, when I get around to talking about a uterine fibroid embolization, we're going to see that that's how we're going to talk about how it works. So an ultrasound is a great screening tool, but it's not effective. I mean, it's not as effective at looking at the uterus as an MRI. So here again, you can see on an MRI, as I was saying, MRI defines the vascularity like here, and it also can identify other conditions, as in this case, where the person has a fibroid back here with a star, but they also have this condition called adenomyosis, which is an overgrowth of the inner lining of the uterus. It is the cousin of something we hear about all the time, known as endometriosis. So when we do an MRI to look at a uterus, we can identify all these problems, and that helps us determine whether or not the procedure is going to be effective or not. Anyway, again, here's another pre-procedure image showing a uterus, which is extremely large and actually has, rather than fibroid, where so if you examine this patient and felt them, you'd see there's a big sort of pelvic mass, but here we see that it is in fact all overgrown with adenomyosis, which can in fact be treated, but it's something that we need to know about in advance. So what are the symptoms of fibroids? Now, the most common symptom that patients present to me with is heavy bleeding. So women will say, well, I used to have normal periods many, many years ago, and now for the last 2, 3, 4, 5 years, I've been having super heavy periods, and it's really debilitating. It affects my life every day when I have my period, and it's really very sad to hear these stories. So the one that's most common that I hear is heavy bleeding. Another one is painful intercourse. You can see based on what MRI I showed before that with the size of these fibroids, if they're lower down, especially near the cervix, it can cause a problem. Other symptoms that are very frequent that we see are frequent urination. As I showed earlier on the MRI, you can see that a fibroid that sits on the front of the bladder will push on the, in front of the uterus will sit and push on the bladder. It can cause severe cramping. And so that's another common symptom, and as well as pelvic pressure or pain. Again, that's what we refer to as the bulk symptoms. So we like to break down the symptoms of fibroid disease into 2 major classes. One is heavy bleeding, and the other one is bulk-related symptoms like pressure on the bladder, pelvic pressure, pain, and cramping, because we can talk a little bit about what the success rate is of treatments depending upon what the symptomatology is. So, many women wonder, well, what's the difference between a normal and an abnormal period? So a normal period usually lasts between 3 to 8 days. An average woman loses about 1 to 6 tablespoons of blood each period, and it occurs every 21 to 35 days, most commonly in and around 28 days. It's a normal cycle. Abnormal bleeding, of course, or abnormal periods is where you have bleeding between your cycles, where you have fatigue, which is often caused by heavy bleeding, or which leads to anemia. If you have severe pelvic pain or cramping, and any period that lasts more than 10 days. So, that's not an uncommon presentation. And one of the things that we see frequently is that we get women who are usually in their mid-40s because these are benign tumors and they take a while to grow. And then they're the ones who all of a sudden, particularly after they had children and now they're not having children anymore, they have an unaffected or unopposed estrogen and progesterone, the fibroids get bigger, and all of a sudden for a year or two, they all of a sudden start to experience much more significant heavy bleeding. So what are some signs that your period is not normal? If you have other symptoms like nausea or headache or dizziness, which becomes difficult to manage. If you're having difficulty sleeping because the cramps are interfering with your sleep cycle, if the cramps last the entire time of your period or continue when it's done, if over-the-counter pain relief medications like ibuprofen and Tylenol do not help, And of course, if your cramps are accompanied by heavy bleeding that lasts more than 10 days. So, we were talking about abdominal pain and cramping and fibroids and how are they related. So, is abdominal pain related to your fibroids? Well, of course, fibroids can cause a dull, chronic pain and pelvic pressure. And you hear many women complain of the same type of symptoms. And especially as you saw from the MRIs earlier, and I'm going to show some more pictures in a little bit, depending upon where the fibroids are, and as they get a little bit bigger and swell during the time of the period, they can really cause a more significant amount of discomfort, certainly depending upon what they are compressing. And we showed that a little bit earlier, and we'll show that again. So what are some ways to relieve the abdominal pain? If you're experiencing severe abdominal pain, of course, we encourage people to seek treatment. We have many women that I like to refer to as silent sufferers. So they, unfortunately, either have a feeling that, well, this is my period, this is what I have to experience, this is just my life. They're either then told that here go on these birth control pills, which many women don't like for other various reasons, and or they say, well, their only other option is to have your uterus removed, otherwise known as hysterectomy, and thus they delay any type of treatment at all. And they really don't have to do that. So of course you can take some over-the-counter pain relief. I don't have to tell women here, I'm sure they've done that, but there are other treatments that are effective and minimally invasive that can alleviate these symptoms. So, studies do show that lots of women will have fibroids by age 50. I mean, 80% might be a little high, but definitely a large number of African American women have them, and certainly there's a very large number of women who do have fibroids. Unfortunately, there are approximately 600,000 hysterectomies performed in the United States every year. That is 600,000 too many, as far as I'm concerned. I think that while the hysterectomy was a great surgery for fibroids 30 years ago, so was a coronary artery bypass graft or CABG for heart disease. That used to be the standard of care, but the standard of care now in heart disease is to open up the arteries using minimally invasive techniques like angioplasty and stent. This is the same thing. There's no reason that most women have to undergo a major surgery when they can have a minimally invasive procedure done to achieve the same outcome. So fibroid embolization is a very effective procedure with an approximate success rate of 90 to 100% for heavy bleeding. I say 90 to 100% because there are lots of studies out there. This surgery has in fact been studied more than any other surgery out there. As an aside, it turns out a lot of surgeries have never really been vetted or validated. Meniscal surgery repair for orthopedic surgery, when it was finally studied, was found that it's not any better than rehabilitation or physical therapy. So you can imagine when fibroid embolization came out and it was competing, so to speak, against this procedure that was done by gynecologists for all these years and was considered the standard of care, the gold standard, it really had to be vetted. And that's why fibroid embolization has been studied extensively and is shown to be extremely safe, extremely effective, with lower morbidity and lower complications and a quicker recovery, period end. It's just a better procedure. It has a quicker recovery. There's no reason why anyone with uterine fibroids, with the exception of a few people, should not undergo a fibroid embolization before they have to undergo a hysterectomy, which most will never ever have to do. So what is a uterine fibroid embolization? So a UFE is a non-surgical treatment for uterine fibroids. It allows us and the patient, of course, to preserve the uterus, which is obviously extremely important, okay? And it's important because when the uterus is removed, it is removed through multiple holes. If it's done laparoscopically, robotically, it may be even through a bigger hole if it's too large to be removed through those small holes. Those can cause problems later on in life. That's what you don't hear about. They can lead to hernias. They can lead to small bowel obstructions because you operated on the belly. This is done, fibroid embolization is as effective as relieving fibroid pain as more invasive treatments, and it's also as effective as relieving heavy bleeding. So who's an ideal candidate? Almost everybody who has a symptomatic fibroid, anybody who wants to avoid surgery, which I would say should be everybody, anybody who wants to preserve their uterus, also really the best choice. There are a lot of nerves around the uterus that get disrupted when a hysterectomy is done. That can lead to problems. You know, people who are around menopause, of course, this is the best procedure. It's a very good bridge to menopause. As I said, menopause is a cure for fibroids. So if you're 48 or 49 and there's a couple years till you reach menopause, there's absolutely no reason to undergo a big operation when you can have a more minimally invasive one that will get you to your goal or outcome. And then, of course, other poor surgical candidates. So UFE is the fastest growing treatment for fibroids. That's 100% true. It is effective at improving bulk or in bleeding symptoms, also true. It's less likely to cause complications, 100% true. And it should be recommended for all women who are eligible. All these are true. Unfortunately, that's not as recommended as it should be because, you know, many people are not educated about this either directly through their internet or other options or by their physicians. So of course, that's one of our goals, is to educate as many people as possible that there are alternatives to hysterectomy. So let's go real quick over what a uterine fibroid embolization is. And I just want to say, if there's questions at any time, I'll try my best to answer them on the fly. Otherwise, I'll answer them at the very end. So don't worry, I'll answer any questions. So anyway, here is an anatomy here, basic anatomy lecture here. This is the uterus. These are ovaries. These are the major arteries that come from the aorta. That's this big blood vessel. So this is known as the femoral artery. When we do a fibroid embolization, what we do is we access the femoral artery typically. We actually now can go from the radial artery, which I can discuss briefly if anyone's interested. Basically, we stick a needle or a catheter into the artery. We place a catheter over the bifurcation, and first usually into the left side, into this little small artery known as a uterine artery. We inject some dye, and then we inject these small particles which go into these vessels. And I always tell people it's basically like taking a big juicy grape, and then as the particles go in, they block the blood flow, and blood no longer reaches it, and it turns into a shriveled up raisin. Now, this does not happen immediately, but usually people have a significant benefit, especially for heavy bleeding, within the first cycle by one period in. Now, most people know that these fibroids will shrink over a period of time. So as much as 6 months to a year, the fibroids will continue to shrink down. But as I said, many women with severe bleeding do really well. And I've seen it be so fantastic. It's like turning off a faucet, and it's really very rewarding for myself and certainly very rewarding for the patient. So we do administer these little embolic agents. There's these little round beads. People worry about them. This is what they kind of look like. They're these little round beads. They're very cool to utilize. We've studied them extensively. They're specifically sized for fibroids. In fact, they're 500 to 700 micron, if anyone's really curious. They're made of materials that have been in existence for a long time, known as PVA, which is polyvinyl alcohol, or triacryl gelatin, which is what goes into embospheres, which is what we use for the standard of care. They've been in forever. If anyone's worried about, oh, I don't want these materials in me, this has been going on now for 30, 40 years. There have been no problems. An interesting story, though, that at one point in time, the company that made the spheres decided that they could impregnate them with gold to make it a little easier for us to see. Turns out that some women are in fact allergic to gold, which is surprising. So that was taken off the market. Anyway, here's a couple pictures. These are my own photos from my own cases. This is a catheter from the right groin. You have to remember this is as if you're looking at the patient facing you. So right and left. You can see there's a big the catheter going into the artery here. And then when we inject, we see this big artery feeding the uterus, and these are the fibroids. Here's another way to look at it. Again, this is not non-subtracted. So again, here's the big catheter. Here's a tiny, much smaller catheter going in, and then it's feeding the fibroid. This is this little microcatheter, and it's feeding these fibroids. We go then flip the catheter. We embolize that side. We flip the catheter and do the other side. Again, this is an interesting way to show it. You can see this big squiggly artery. That's the artery to the uterus. And, you know, you might have to take my word for it, but that's well established. It's the first division here. And then again, looking at it in another way, we can now see that this is the fibroids, and all these squiggly arteries are abnormal arteries feeding this thing. So we treated the one side, then we treat the other side. Then sometimes we take a picture here to show now that there's no more flow. In addition, there's no additional blood supply to the uterus. So here's a couple pictures. These are donated by Dr. Jim Spies, one of the preeminent uterine artery embolization doctors. The reason these pictures come from him is that back in the day when the research was being done, we were able to get an MRI on every patient, every 6 months to a year. Now that's not feasible. So in any event, here's a big uterus with a big fibroid here. You can see after 3 months, it's already shrunken down a little bit, and there's an area here that's getting smaller. And again, this is at a year. The uterus is starting to regain a normal shape. 2 years, 3 years, and finally 4 years. This is basically a normal uterus compared to here. You can see the massive difference. You can see, though, that even here, at this point, there's been a significant improvement, which is why I say within a month or two, almost every woman who I know who have ever treated has had a tremendous benefit. So what are the benefits of fibroid embolization? There's no surgical incision and no general anesthesia. It's covered by almost every insurance plan. In fact, I don't know any that do not cover it. There's a shorter recovery period than surgical treatments. There's no hospital stay. We do these on an outpatient basis in our offices. It preserves the uterus and its function, so there's no subsequent consequence from removing it. And you can return to daily activities within 1 to 2 weeks. In fact, some of my patients return to activity within 3 days, particularly when we use a radial or wrist approach. There's a question here that do fibroids return? That's an excellent question. Most of the time they do not, particularly around women who are in their mid to late 40s. The chances of them returning are almost zero. If we treat someone who's younger, like in their late 30s, it is feasible that at some point they return. Sometimes they return because the person or the operator who performed the procedure did not embolize the entire uterus or did not embolize it to completion. So in fact, it is feasible to do a repeat procedure at some point down the line if they in fact return. But in general, the fibroids do not return, but it's an excellent question. So I just added in a couple questions that I get a lot. What about adenomyosis? So I showed earlier, adenomyosis is the cousin of endometriosis. So it's ingrowth of the inner lining. And what we have shown is that this procedure can be effective against adenomyosis. It's just not as effective as fibroid disease, which is one of the main reasons why we get imaging beforehand. We want to know what we're dealing with. And sometimes an MRI is really the best way to see that. So sometimes there's an overlap. There's two diseases, adenomyosis and fibroids. I'd like to know which one is predominant so I can have an effective discussion with the patient. But it certainly is a treatment option for women with adenomyosis, but I think it's something that we have to discuss and be appropriate with our expectations. And, that's something that both myself and then the patient needs to be aware of. Pregnancy, another big question. So for those who wish to retain their pregnancy option, obviously hysterectomy is not an option. But there are procedures for women who have infertility issues that may be used in conjunction or instead of uterine artery embolization, such as a myomectomy, where they go in and they just take out 1 or 2 fibroids. If in fact we get an MRI and we see one easy fibroid to remove, I totally understand that myomectomy is probably a better option. However, there are many women for whom there's more than one fibroid, or maybe 5 or 10. You're not going to be able to get them all out. And in fact, you're not going to know which one is the cause of the problem. And there are plenty of patients who have had a fibroid embolization and then gone on to have a normal pregnancy. There's even studies about that and showing that it's a safe, effective treatment and one that does not lead to any additional birth defects. Wrist or groin is one of the final ones. I do both. Some of it is my preference, some of it is a patient preference, some of it is a combination of both. The groin is what we started with, and I've done countless numbers that way, and that's how I began. And so it's really the one that's used most frequently, but the wrist, which is the radial artery right here, is also very straightforward. You wonder, hey, why would you stick me here when the problem is here? Well, the bottom line is all roads lead to Rome. So you can start in the wrist, take a catheter up the arm, and then down here, or you come from the groin. Either way, you end up in the same point. So you can either come from above or come from below, and both work just fine. With the wrist, we put a little Band-Aid on there. It's a little tight, and then we take it off after an hour, and you're free to go.